Since the platelets and red cells adhere differently to foreign materials, the filters which are used for packed red cells and platelet concentrates cannot be used interchangeably. Similarly, if we have a filter which is integral with the collection unit, the whole blood collection unit, it would have to be a platelet sparing filter, whereas a filter which is used for red cells would not be a platelet sparing filter. The current generation of filters allow for a 4 to 5 log removal of leukocytes, and in addition to this, are also known to have effect on removal of bioactive substances such as C3A, C5A, rantis, and CD40L, and other microorganisms such as bacteria. The clinical benefits of leukoreduction, there are different levels of clinical benefits which are known. We have the proven benefits which are relevant clinically, and these are known and studied in various studies. These are the reduced frequency and severity of febrile non-hemolytic transfusion reactions, reduced risk of CMV transmissions, reduced risk of HLA alloimmunization, and platelet refractoriness. There are a wide variety of other effects which are not known to be clinically proven, or they are not studied as well as the proven benefits. Coming to our study, our primary objective was to assess the changes in the packed red cell associated hematological indices following leukoreduction. The secondary objective was to evaluate performance characteristics of the leukoreduction filter used. Materials and methods, we have leukoreduction, which is done on a routine basis for our patients because they are oncology patients. So they require the leukoreduced products, especially the patients who are posted for transplant. So the filter that we use at our institute is a Mako Pharma filter. And our study was a retrospective study done of the quality control records maintained in our department. Any red cell concentrates which are subjected to leukoreduction were studied in this study. So the variables which were assessed for this study were the quality control of the pre-leukoreduced samples and the post-leukoreduced samples. We took the representative tubing samples, and it was run on an automated analyzer. And these are a wide variety of variables which are assessed pre and post, as well as the difference between the two. And for the leukoreduction filter performance efficacy, we had these set of variables which were tested. We had around 90 automated analyzer reports and filter performance records. So the analysis that we performed for this was we checked for the change between the pre and the post leukoreduction samples. We assessed for a relative change and compared it with other pre-leukoreduction parameters to assess whether there were any interrelated effects between the parameters, whether a particular parameter was being affected by other parameters. And we checked for the correlation in those parameters. And only significant comparisons have been depicted in this presentation. So as we know, white blood cell, it's a leukoreduction filter. So that is obviously going to show a statistically significant decrease. But as we use the automated analyzer reports for the same, this showed only a 2 to 3 log reduction in the leukoreduced cell product. But estimation by the Najat's method proved that it was actually a 4 log reduction. Other parameters which were tested were the red blood cell count. There is some amount of volume which is held up in the filter casing itself. So that would definitely have an effect on the red blood cell count, and that was a statistically significant decrease. Coming to the mean corpuscular volume, the MCV measures the average volume of the erythrocytes, and there was a statistically significant increase in the MCV noted after leukoreduction. This was one of the parameters wherein the relative change was found to correlate with another parameter, and that was found to correlate with the hematocrit, and there was a positive correlation, that is, higher the hematocrit, there would be a greater change in the MCV in the post leukoreduction sample. In addition to the WBC count, we also found that the platelet counts were decreased due to interaction with the filter housing, and it was equivalent to a 1 log reduction in the leukoreduced sample. Other hematological indices, although showed some differences, but they were not found to be statistically significant in the analysis. Coming to the leukocyte filter performance characteristics, we obviously had a statistically significant decrease in the white blood cell count in the leukoreduced unit. Red cell concentrate volume, we have a certain amount of volume which is retained within the filter, and that amounted to 30 to 40 ml across the units which were tested, and this loss correlated to around 10% across all the units which were tested in our institute. Red blood cell count, this was in correlation with the amount of red cell volume which was lost. There was a statistically significant decrease in the volume. And another analysis that we did was the change in the red cell indices, which was compared with the time taken for leukoreduction to assess whether the time which is taken for the leukofiltration is having any effect on the amount the parameter is changing in the post leukoreduction sample as compared to the pre. So we found the only two parameters, that's MCV and the CHCM, where we found a negative and a positive correlation, and it was statistically significant. Coming to the discussion, we know leukoreduction is needed. It has to achieve a 4 to 5 log reduction, and we have a number of studies which reported different levels of log reduction. But these obviously had different configuration of red cells which are used, as well as the leukofilters which have been used. And it is well known that automated analyzers are unable to accurately determine the WBC content of a sample when it is leukoreduced. So Najat's method is obviously preferred in resource constrained countries, apart from flow cytometry and PCR for residual WBC enumeration. Coming to the mean corpuscular volume, we had a few studies which compared the change in the mean corpuscular volume. Our study showed a statistically significant increase in the MCV. Pertines et al. Was a study wherein they put forth the hypothesis that leukodepleted RBCs are characterized by a higher deformability that would favor their passage through the filter and are more resistant to cell volume impairment during storage. Phelan et al. Was another study which found that the leukocyte activity, which would have its effects during storage on the red cell membrane, would result in greater distortion of the RBC morphology and may contribute to their storage lesions. Comparison of MCHC, although a study found no statistically significant change in the MCHC, there was another study which did find some significantly higher MCHC in unfiltered units as compared to leukofiltered units. And they also assessed the change in the MCHC occurring over the storage duration. And it was noticeable that the decrease of MCHC occurring over storage duration was much greater in the unfiltered group as compared to the leukofiltered RCC. Platelet depletion, again, there are a number of studies which reported varying degrees of platelet reduction, with the highest being reported of 98, around 98% in the study by Heaton et al. This could be attributed to the variations in the leukoreduction filters as well as the counting methods employed, as we know that the sensitivity for platelet count at less than 20,000 per microliter is variable among different automated analyzers. Coming to the time taken for leukofiltration in different studies, our study, we were using the Macropharma Leucolab filter, and the configuration was SAGM PRBC. It was filtered at room temperature. The time taken for our filtration varied from 13 to 25 units with a median of 22 minutes. And we have a wide variety of configurations over here. We know very well that the temperature has its effects on the filtration time, as well as the various leukofilters used. So that could be some of the differences between our study and the others. Filter performance characteristics, the red cell concentrate volume, there was a statistically significant decrease, which is inherent loss occurring in the hold-up volume of the filter casing. WBC count and RBC count showed a statistically significant decrease, and MCV showed a negative correlation to the time taken, whereas the CHCM showed a positive correlation. It could be a function of the physical characteristics of the leukofilter and the material used in the production of it. Coming to the conclusions, the current generation of leukofilters are effective for the process of leukoreduction. The inherent hold-up volume of the leukofilter leads to red cell losses, which average around 8 to 10% of the initial volume. Approximately 90% of the platelets present in the unit were filtered out, may contribute to additional beneficial effects such as decreasing alloionization. Our study was unique that a number of red cell indices were estimated during the process of leukofiltration. Changes were seen in the RBC count, MCE, MCHC, and MCH, but there were a number of red cell indices which were unique and were not studied, although these were not statistically significant. A relative change in the indices was also something that we did differently, wherein it was compared with the pre-LR parameters to assess for interrelated effects among the hematological indices. The leukocyte filter performance characteristics among different manufacturers may be compared when making a decision for the institution. The most important would be the time taken, the temperature required, as well as the number of days within which it can be used for filtration, and cost also may be another significant determinant for selection. Further studies at a microscopic or structural level would be necessary to understand the impact of these changes on the red cell concentrates in vitro, whereas in vivo studies using labeled erythrocytes would help in determining red cell recovery. This would then throw light on the functional heterogeneity of the selected RBC population occurring following leukoreduction. The prohibitive cost of these tests makes this less feasible, however, to be studied in a routine blood center setting. These are my references for the studies. Uh, Thank you.